Welcome to the interview by Media Hanger. It's good to have you here with us today, Dr. Sreedhar. And today we're going to be talking about, a potential third wave of COVID-19 and how we can approach childcare during the third wave. So before we just get going, would you like to tell us a little bit about yourself and what you do and your work at Rainbow?
Thank you, Sresh. It's a pleasure to be with you today to talk about COVID. I'm Dr. Sreedhar. I'm a consultant neonatologist and pediatrician at Rainbow Children's Hospital, Hebbal, Bangalore.
Okay, thank you. And I just wanted to begin this conversation by asking you about a potential third wave, right? And a lot of news has been coming up about the third wave, what's going to happen, who's likely to be most affected. But a lot of recent news suggests that unlike the first and the second wave, it's unlikely that children will be affected disproportionately, if there even is a third wave, that is. And from what we've seen from the first and the second wave, this result or this conclusion seems to be a little counterintuitive because people seem to think that children will be affected, even though doctors and a lot of recent reports are telling them that that's not going to be the case. Could you tell us a little bit about that and why some people believe otherwise?
Sure. So it's a very good question. In fact, it's very pertinent to a lot of discussions that have been happening right now. What is undeniable is that there will be a third wave for sure. And unfortunately, there will be many more subsequent such waves where there will be a spurt of COVID-19 cases in the community. The only thing that is in question is what would be the severity of patients who get affected in subsequent waves, and who is going to get affected more, how many cases will be there, and what would be the time frame, when exactly is this wave expected. So there are a lot of doubts about it, but have no doubt that we will definitely have a spurge of cases in future as well, unless a vaccination drive takes a booster and a lot of adults get vaccinated, and in spite of the government lifting bans on lockdown and stuff, people do behave responsibly, don't come out of their homes, wear masks, practice social distancing. Unless these things are done, third wave is bound to happen. So have no doubt about it. Now the important question here is whether children would be disproportionately affected during the third wave or not. A few weeks earlier, the talks were that more number of children would be affected in the speculated third wave than in the first and second wave. So that was what they were saying, and probably this was based on the fact that towards the end of second wave, there are a lot of children with COVID, and more than COVID, there is something called post-COVID multiple inflammatory syndrome, multi-system inflammatory syndrome in children. So considering this, there were some doubts that children may be disproportionately affected. However, now we have evidence, scientific evidence. So what does the evidence say? There was a large study conducted by the All India Institute of Medical Sciences, Delhi, along with the World Health Organization, where they took almost 10,000 sample sizes, 10,000 individuals from the community across 5 states. And now we have an interim data of close to 5,000 of these samples. So they basically looked at how many of the individuals included in the survey were actually positive for COVID antibodies. So if an individual is tested positive for COVID antibodies, it means that they were infected with the virus. So basically the study was to find out how many of these were infected. So surprisingly, the study reports say that less than 18 years, the incidence of infection, the individuals who were infected is somewhere around 73%. And more than 18 years, it is somewhere around 69%. So in the first and second wave also, children were not disproportionately affected. But what you should understand and what's there is that, of course, the number of cases that were reported from children were less. It does not mean children were not affected. So the reason why probably less reporting in children happened because most of the children remained asymptomatic. And even in symptomatic children, many times the symptoms were mild. And there was some hesitation from parents' side about testing a small child for COVID. So all these things would have reported in gross underreporting of cases in children. So probably that is why, if you look at the previous data, about 2 to 3% of the children were affected is what it says. But then when we did the zero prevalence study, it clearly says that less than 18 years and more than 18 years, the virus is not differentiating between people based on age. It's equally affecting children and adults. So third wave will be there. It is less likely that children would be disproportionately affected. But just like the first and second wave, we will see cases in children also. But fortunately, cases will definitely be mild in severity, and the complications will be definitely less when compared to adults.
So, I mean, you just mentioned that children have been affected by COVID during the first and second wave, but more often than not, their symptoms have been relatively mild, or they've been asymptomatic altogether. But the question that I have, to that is whether this could be attributed to some kind of mutant strain of the virus, which tends to affect older populations more. And we saw that, right back in 2019, early 2020, when COVID was beginning to show itself to the world, we saw that either infants or really old people got severe bouts of COVID compared to the rest of the population. Now, after that time, there have been different mutant strains of COVID that have been coming about. So is it likely that that is the case, why children are not being affected as much? And is it likely that we might see more mutations in the future, particularly ones that might affect children?
Okay, so again, a great question. You really explained it well, saying that children were less severely affected compared to adults, and I concur with you. There are a lot of hypothesized reasons for this. I say hypothesize because we don't have enough solid scientific evidence to say why the children are, why the disease is less severe in children. But however, from a lot of evidence from other viral infections in the past, and from the basic science that we know about children and their immunity, certain reasons have been speculated and they have been proposed. So it has got to do with the disease being both less severe in children, and also the disease tends to be more severe in adults. So if you look at why the adults get more severe illness, there are several reasons for it. Number one, the chances of coexisting illnesses are more in adults. For example, uncontrolled diabetes mellitus, uncontrolled hypertension, and underlying heart diseases, underlying kidney diseases. So all these things are more common in adult individuals. Hence, when COVID affects these individuals, the symptoms would be severe. Second, age-related changes do happen in our immune system. There is actually something called immunosenescence. With age, the immune system loses its certain of its important functions. The ability of the immune system to clear the virus comes down. So certain immunity factors are stronger in children when compared to adults. So this effect of aging on immunity has got to do with higher viral loads and more severe disease in adults. Then there is another concept called inflammaging. Although the word sounds a little uncommon, it simply means that we all have heard the word inflammation, where the body is trying to attack itself. Now, there is something called low-grade chronic inflammation. Means it has been happening for a very long time at a very low intensity in adults, per se, even without COVID infection. So this has got to do with why the blood vessels in the heart get blocked because of lipid deposition, because of fat deposition. So they already have a substrate, underlying substrate, and when the COVID virus infects them, the disease becomes more severe. When you come to children, there are a lot of protective effects. So one of the important things, as I told you, they have a different kind of immune response, which can mount stronger immune response to viruses. So virus clearing could have been better. And then, see, when this virus actually infects human beings, it actually binds to a protein molecule present on the cells of our respiratory system. This protein is called AC, angioconverting enzyme. So these proteins are less expressed in children. So chances of virus infecting and getting entry into the children's the body of the kids is less, because the protein that is necessary for the virus to get into the body is less in children. Third thing, many of these children have active immune response because of the vaccines that they are regularly receiving. So this is another very valid reason to get all your children vaccinated according to the regular schedule that we have. So there is some evidence which says that some of the commonly used vaccines in children, like the BCG vaccine, which is actually used against tuberculosis. Then we have something called MMR vaccine, there is measles, mumps, and rubella virus vaccine. So when they looked at large cohorts of population, the populations who had received BCG and MMR vaccine actually had less severe diseases. So, and children, most of the kids would have received this. So this may actually play a role. And also many kids will have concomitant other viral infections. You all know viral infections are more common in children. So whenever a virus has recently infected a child, the chances of COVID, again getting infecting the child, and the way COVID manifests within oneself may be different. So these are basically the host factors, means the things that are intrinsic to a child's immune system and an adult's immune system, why COVID is less severe a disease in children. Now coming to the virus factor per se, you mentioned that the disease being less severe in children could also be because of viral mutations. Again, that is a hypothesis. It has not been proven. The most rampant viral mutation was the B.1.356, which actually caused more infections and little severe infections even in vaccinated individuals. But there is no evidence that this strain particularly affects children or it causes more severe illness. So coming to the end, the question that you asked, will there be a mutant strain of virus that may affect the children and cause a more severe disease? The answer is it is possible, but it is less likely, considering our understanding of immune system and our experience from past viral infections affecting children and the way COVID has behaved in the last 1.5 to 2 years. It is less likely that we'll have certain specific mutations which can cause severe disease in children.
Now, speaking of vaccines specifically, even though globally the proportion of children that have been vaccinated to COVID is far less than adults and older people, do you know what the current medical consensus is on the efficacy of the existing vaccines, whether it be Covishield, Covaxin, Pfizer, Moderna, whatever, the efficacy of those existing vaccines on children, if there is any consensus currently?
Okay. So again, a very pertinent question, COVID vaccines in children. Just to give you a little background information of how a new vaccine or how a new drug comes to market. So they are initially tested in healthy adults and then in other high-risk population. Once we have enough data of their efficacy and safety, then we move to vulnerable populations like pregnant women, breastfeeding women, then children, particularly adolescents of 12, 14, 15 years, and then lesser age. And the last would be infants, less than 1 year. So right now, Pfizer BioNTech vaccine, they recently completed a study in children between 12 to 15 years, and they included close to 2,300 children, and interval between doses was 3 weeks. 7 days after the second dose, they have demonstrated 100% immune response to this vaccine. And several countries have actually licensed the use of this Pfizer vaccine in children aged more than 12 years. But currently, the vaccines that are available for public use in India are Covaxin and Covishield. They are not approved for children less than 18 years. Now, what happens is before these vaccines receive a nod from the authorities for regular use in children, there are certain mandatory trials that they have to undergo. So right now, phase 1, 2, 3 trials are actually being done on children with these vaccines, especially Covaxin trials are already going on. AIMS has started doing trials for children aged more than 2 years, and there are many centers are doing it for children more than 12 years. But the data of these trials is not out yet. So once we have data from trials of our currently available vaccines on children, then only we'll be able to say what is the efficacy and what is the safety. So lack of data does not mean that these vaccines are not safe or they will be less effective in children. Again, considering our understanding of how the vaccines work and experience with other vaccines, most researchers are speculating that most of these vaccines would be safe and they would be effective in smaller children as well. So just a matter of time before we receive a nod from the government authorities for using these vaccines in children.
Right. So maybe that that answer also sort of answers the next question that I was going to ask you, which was in case of, say, lower efficacy of existing vaccines, or even in the case of, even if vaccines are effective for children, would we hypothetically see a future where vaccines are engineered based on very specific target populations, say according to age group, sex, any of that, or even further in the future, perhaps I'm being a little more contemplative here, but maybe even according to the individual, would that be a possibility?
Okay. So essentially, it's an era of customization, isn't it? Everybody wants their own vaccine tailored, anything for that matter, tailored to their needs. So as you mentioned, it's speculative. See, right now we are in exemplary situation. It's a pandemic. Although close to 1.7 billion doses of vaccine have already been administered, it has not even covered 5% of the global population. So right now the efforts of the research community, government organizations, private establishments would be to get as many doses of the available vaccines as possible. I doubt if there is any effort that is being put into this individualization and improvisation of the vaccines. But then again, if you look at how vaccines work, most of the vaccines that are used in children can be used in adults also. Some of the vaccines we may have to use a higher dose depending on the weight and age criteria. But the composition of the vaccine and the basic way the vaccines work wouldn't be different between children and adults. So I don't think there will be any vaccines that are specifically designed to be used in children, and probably it will just be some dose changes. Already there are some vaccine manufacturers which are recommending some different doses scheduled for adolescents and smaller children, but probably that is all that we may see in future. I don't think there will be any drastic differences between vaccines for children and adults.
Saying, why fix something that's not broken already? So to go to a slightly different line of question, I've been told, and I've also read, that the manner of caring for COVID positive children is different from the manner of caring for COVID positive adults. And I understand that naturally that would be the case. Now, could you tell us a little bit about why that is and how that care differs? And in the case of COVID infected children, what are the steps to be taken, like immediate steps and future steps to be taken to combat the virus, as well as how they're different from adults? Okay.
So essentially the question is, how do we manage a child who is infected with COVID, and how different it is from managing an adult? The fundamental concepts are the same. We actually have to treat the patient, treat the child, and not just the report. Just because a COVID report is positive, I don't think that actually changes the line of management so much in a child who is asymptomatic or is having mild or moderate symptoms, because the line of management is essentially similar to any other viral infection. So I will divide it into a few things and try to simplify it. If a child is COVID positive, does not have any symptoms, then you don't have to do anything. All you have to do is make sure that the child is hydrated well, drink a lot of water, fluids, buttermilk, fruit juices, things like that, and probably keep a watch on the child's fever. If at all, if the child is fever, that means the child is symptomatic. And if you look at the most common symptom of COVID in children, it is fever. And most of the times this fever responds very well to common medications used for fever. I'm sure every parent knows Like paracetamol is a common medication used, which has to be administered every 6 to 8 hours based on the intensity of fever. And again, there hydration becomes extremely important. So even if a COVID positive child is having fever, first 48 to 72 hours, all you have to do is keep the child well hydrated and give medication to decrease fever. That is just symptomatic treatment. If the fever does not come down by third day, or if the fever is very high, or if the child has any other warning signs like persistent vomiting, the child is not eating anything, child is looking sick, is irritable, or is excessively sleepy, or has developed rashes over the skin, or the eyes are looking very red. So any of these warning signs are there, then you have to seek medical attention. So generally what happens is between third to fifth day, even in children who have moderate symptoms, we monitor them and we do some basic blood investigations just to see what is the severity of illness and if there are any complications. So world over, only 3 to 5% of children who are infected with COVID fall into severe category. Severe category in the sense, if they have breathing difficulty, if their blood oxygen level is coming down and they need oxygen. So only things like this warrant an ICU admission, and only there the management strategy differs. So most of the times you don't have to do anything, stay at home, probably consult your doctor by video consultation. For asymptomatic children, nothing is needed except nutritious diet. Mild symptoms like fever, give paracetamol. Fever not coming down by 3 days or any of the warning signs I mentioned, seek medical attention. The only difference in adults is that in addition to keeping a watch on fever, many of the adults, especially the elderly population, and also those with underlying diseases, you may have to monitor oxygen saturation. So generally beyond after fifth, sixth day, the oxygen saturations may start to drop. And this can happen without the patient knowing that the oxygen saturations are dropping. So normally our blood oxygen saturation is more than 95%. And when the oxygen saturations start dropping, we'll have some symptoms like breathlessness, fatigue, dizziness, or something like this. Whereas in adults with COVID, there is something called happy hypoxia. Hypoxia is low oxygen, but the patients are unaware and they're happily roaming around. So it's very important to catch this hypoxic event during this interim period. Means the patients have not yet become serious and you notice that the oxygen saturations are borderline. If you start treatment at this stage, the outcomes are going to be much better. So small children generally don't have this kind of a presentation, although adolescents, children more than 10 to 12 years, especially if they are obese, there you may have to keep a check on oxygen saturation. It's difficult to measure oxygen saturation using finger pulse oximeters in small children. So you don't have to do it. As they keep moving, saturations are all over the place and parents become anxious. But an adolescent child, an older child, especially if they're obese, then you have to monitor that.
Right. So, similarly, you've clarified that children being infected by COVID-19, they tend to have milder symptoms or they tend to be asymptomatic. And we can see the trend that, in the second wave and probably even before the third wave, a lot of people, if not a majority proportion of adults, will be vaccinated at least with one dose of any vaccine. And for the last year or two, wearing masks and obviously social distancing, but primarily I'm talking about wearing masks, it has become the norm, both for adults and children. But I also have come across opinions which state that children don't need to wear masks because of the adverse effects that it might have on their developmental years. And those developmental years, obviously, we know that they're crucial to building a healthy foundation. And considering the fact that a lot of adults are going to be vaccinated and the transmission of COVID typically happens from person to person, and children do not develop as severe symptoms, is it really advisable for children to wear masks? As in, what is your opinion on children wearing masks? Is it useful or is it less useful?
Okay. The current recommendation is that children aged less than 5 years need not wear masks. But more than 5 years, I would definitely say teach the children to wear masks. And there are certain basic behavioral changes that has to happen, whether it is a child or an adult or whoever it is. And this is something that we have to inculcate in our lifestyle. Basic cough etiquettes. So when you are coughing, cover your nose and mouth using a handkerchief, or at least cough or sneeze into your elbow so that the droplets that are produced during these events do not spread to the person around you. Don't spit everywhere. Wash your hands. You come home, you wash your hands, take breath, take bath, and avoid spreads only by so-called droplet infection. That means the respiratory secretions are actually slightly bigger. They're more than 5 microns in size, and they do not travel for a distance more than 1 meter. So even if someone is coughing and you maintain a distance of more than 1 meter, it is less likely that the droplets are going to fall on you and you acquire the infection. So if two individuals, let us say there is a COVID positive patient and that person is wearing a mask, is wearing a head shield, and you are standing 1 meter away from that person and you are wearing mask and you are wearing head shield, no matter how long you stay in this situation, the chances of you getting infected is less than 5%, which is quite good. So wearing mask and following cough etiquettes, following social distancing. So this collective behavior is the best vaccine. Please remember, vaccines that are currently available are extremely effective. Most of them quote more than 90-95% efficacy. This efficacy is for serious illness. If you speak to any intensive care physician caring for COVID positive adults, they'll tell you very rarely they have seen any person in the ICU who was very sick, who had actually received both the doses of the COVID vaccine. So these vaccines are extremely good in preventing serious disease. But asymptomatic infections can still happen in vaccinated individuals. So those persons can get infected, they would not know that they're infected, and they can spread to other people. Who are these other people? People who are not yet vaccinated. Second, people who may be vaccinated, but still their immune response may be muted to vaccine. For example, elderly people, more than 80 years, even with vaccination, the efficacy is much less when compared to a 40-year-old person. A person might have an underlying renal failure, maybe undergoing dialysis. There, the efficacy of vaccine is less. Or if you have a small child at home, or someone who has missed their vaccine. So still, a vaccinated person can spread the infection to others. So there comes the responsibility where, whether you're vaccinated or not, whether the person beside you is vaccinated or not, please wear mask, please maintain social distancing, wash your hands frequently, and follow basic cough etiquettes.
Right, because I also guess that a lot of the I guess measures that you've outlined right now would be useful not only because of COVID, but also in general daily hygienic practices, right? Because I wonder if I'm right in assuming that a lot of other infections like the common cold spread in similar means as COVID. Would that be right?
You are 100% correct. Most of the respiratory viruses spread by 2-3 mechanisms. One, droplet mechanism is common to most of the respiratory infections. Second is something called fomite. That means you cough, the droplets, they fall on surfaces, and then someone else comes and touches them, and then they touch their nose, face, and gets infected. Very rarely there is aerosol spread.
Right.
So all these COVID appropriate behaviors that I've been talking about significantly reduce the risk of transmission of many other viral infections like flu, like common cold. The chances of wheezing has come down in children. Generally, at around this monsoon season, we see a lot of flu-like illness, influenza, wheezing episodes. That is significantly less. A lot of diarrheal diseases has come down because most people have started washing their hands, and eating from outside is avoided to a great extent. So these COVID appropriate behaviors not only help prevent COVID infections, but has been successful in decreasing many other infections also.
Right. With that said, though, is it a valid concern for children and especially parents to have that their child could possibly be doubly infected by both COVID as well as some other viral infection, and that might, increase the symptoms? Or is that a valid concern to have?
So the question here is, in this COVID, during COVID infection time, have the other infections come down, or is it possible that a child can be simultaneously infected with COVID and other viruses or other bacteria? So it's called co-infection. In fact, that is a commonly asked question by parents and caregivers. So a child with fever doesn't mean they always have COVID. So they can still have many other infections. It can be simple common cold, it can be pharyngitis, it can be a flu-like illness, it can be urinary tract infections. So all these are still a possibility. But whenever there is fever, for all practical purposes, we should consider it as COVID, and we take necessary precautions so that we prevent the spread of infection to others in the family and the community. So thereby you are doing yourselves a service amongst the family and to the society as well. But these co-infections are always a possibility. Ours is a country where infections are at the top of the list as the cause of hospital visits, as the cause of serious illness, mortalities, everything. In fact, we have had patients where a child was positive for both dengue test and COVID test. Although this is uncommon, so the answer to your question is, child can be simultaneously be having other diseases. But then we suspect this only in children with moderate or severe illness, fever continuing beyond 3 to 5 days, or if they become sick, then most clinicians do rule out other possible and other common infections, then we treat them.
When there is the rare case of a child being co-infected, would it be that the symptoms are twice as bad, or would it be pretty much the same as, any other infection? Is it, my question is it possible that the child is going to be much more severely affected than normal?
So the spectrum of illness, where it depends on a lot of things. It depends on what is the co-infection and what stage of infection it is, and how severe is that secondary infection affecting the child, and how is the child mounting its immune response. But I would say most of these we should still be able to manage them, although the severity of illness can be a little more than what it would be if the child were to be infected only with COVID. But I would say most of this we should be able to manage, although they may cause more severe symptoms.
Right. Right. So that's about all the particular questions I had for you about childcare during the third wave of COVID. Summarily, we found out that there is going to be a third wave, but as you mentioned, it's going to be a little milder, especially on children, and it's manageable. So that's optimistic, and that's a positive note to end on.
In the sense,
yeah.
In the sense, I do not expect a drastic difference in how the COVID was in first and second wave compared to the third wave. So the patient profile that would be seen in third wave would be probably similar to first and second wave. Children would be affected, but they will not be disproportionately more affected, or we probably will not see a disproportionately severe illness in children.
Right. Okay. Yeah, I'm sure that puts a lot of fears to rest, especially in parents also. And I just want to end this conversation. I just want to open up the space for you to maybe say what you would like to say to any children or any parents watching the video, anything that you have in mind, any advice that you might have for them, whatever you would like to say here.
Sure. So I would like to tell all the parents that I do understand that it is probably the most difficult times of all our lives to deal with such an unknown disease which has caused so much of pain and loss across the globe. But then we have now understood the disease. We should all be informed that the disease is less severe in children. Even if the disease presents with severe manifestations, if we catch it early, then most of the children with severe COVID should also be able to come out well with timely treatment. So the need of the hour is that all of us should get vaccinated as soon as possible with whatever vaccine that is available. And then once you get vaccinated, we should not let go of our guard. We should still wear masks. We should practice hand washing. We should maintain social distancing. And whenever a child is tested COVID positive, don't be anxious. Most of them do well. You have to keep them well hydrated. You have to give them nutritious food, and then seek your doctor's advice. At the same time, this is a time when there is a lot of impact on the mental health, the behavior of children and everybody in the family. So you should all find a way to spend time together in a healthy way. Physical exercise is extremely important. Indulging in whatever play that you can do with your kids will be very useful. Do not, I mean, it is understandable that with all the restrictions, you might have missed some of the regular vaccinations for your children. But now the restrictions are off. You please maintain, make sure that all the kids receive their regular vaccinations. Stay home, stay safe.
All right, lovely. Thank you. Thank you so much for coming on today. It's been a really insightful and also personally enriching conversation for me. So I'd like to close on that note, and thank you particularly to Rainbow Hospitals and especially you, Dr. Sreedhar. I'm sure this conversation is going to be useful not just for me, but for a lot of people listening also. So once again, thank you, and I will sign off on that note.
Sure. Thank you, Srish. It was, as I said, the pleasure is mine. I just hope that this thing is helpful to a lot of people. Thank you so much. Thanks for the opportunity.